How many people are excited to be here for the OHDSI Symposium? That was only lukewarm. How many people are excited to be here for the OHDSI Symposium? There we go. Now we're talking. Now we're talking. Okay. Well, I'm excited you guys are here too. And I'm very excited to get to participate and present on behalf of a pretty large team that has put together what George said was literally unbelievable. I do believe it because I've seen it. But I will say that just being a small part of this project, I feel like this, what we're going to show you, I think, is the scientific accomplishment that I'm most proud of in my career. So just to set a bar just a little bit. But I'm not actually going to present any cool results. I'm just going to actually give you a little bit of a motivation for the problem that we thought about solving. And hopefully get you as excited as we are about the work that we're doing, that we're sharing for the first time today. So this session, myself, Martijn Schuemie, Marc Suchard, we are going to present a sequence of presentations to try to tell you the journey that we've gone through in thinking about how to generate reliable evidence from observational data to address a specific clinical domain. We're going to talk a lot about hypertension today. And you saw in the agenda that we have this new acronym, the Large-Scale Evidence Generation and Evaluation in a Network of Databases, or LEGEND. And what we're actually unveiling for the first time today is LEGEND, the learning healthcare system, or at least a vision of what we think a learning healthcare system could look like, and not only a system that could generate evidence, but actually the evidence itself. So you saw this in George's presentation. I think it's very important to situate what we're doing. We're all here because we believe as a community in a shared mission. And that shared mission is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. And each year we think about so this is an aspirational statement, but each year we think about what could we do that would actually fulfill this mission? What could we accomplish as a community that would be useful? And sometimes we actually need to rack our brains about, like, what question should we focus on, what clinical area might be interesting. But it turns out this year this was not a hard problem. Because, again, show hands those of you who came last year. Right? Okay, about a half of you. And so you remember that was like late October. And those of you who came last year, how many of you had a good time? Okay, I feel like I got some extra hands. People that weren't here still had a good time. So end of October, beautiful time of year, particularly here in Bethesda. Okay, so that was end of October. And so, we took maybe a day or two to have a beverage and decompress. But then we said, okay, what are we going to do for next year? How are we gonna do something better? And we were trying to figure out, like, well, where are we even gonna get a good question from? And then mainstream media hit. First week in November, so only like 2 weeks after the symposium, on CNN.com, this was the headline. It said, nearly half of Americans now have high blood pressure based on the new guidelines. And this screenshot, CNN talked about their reporter talked about their interpretation of the fact that the ACC and AHA and all of the professional societies got together in the US to release the new hypertension guidelines. And they keyed on with this title one specific guideline, which was that they've actually changed the definition of hypertension and changed the thresholds of systolic blood pressure, which now probably is going to mean more people will be classified with hypertension based on these guidelines. And this article from CNN, it had like a nice little video for the lay person who's going to go to this page and say, like, wait a second, I got hypertension now. They provided this nice little informative video that I just got a screenshot of. And the video basically says, this is what hypertension is, and hypertension's serious and might cause bad cardiovascular events. But there are treatments like diuretics, beta blockers, and ACE inhibitors that can be used to treat this disease. So it wasn't just CNN that bothered to cover this story. Wall Street Journal on the same day also had their own beat reporter cover, and they picked on that same guideline, that nearly half of US adults will now have high blood pressure under the new guidelines. New York Times also picked up the article, and it said, under the new guidelines, millions more Americans will need to lower blood pressure. And what I love about this particularly is there were millions of people who were going to have high blood pressure. So why on the front page of New York Times did they pick this individual wearing this t-shirt? Right? Are you telling me that was the best hypertensive person they could find? Anyway, that was New York Times' decision, not mine. So there was a lot of mainstream attention about the fact that this guideline came out, and particularly this classification of blood pressure. But pretty soon thereafter, there started to be some scholarly conversation about this as well. And actually, New York Times, just 1 month later, published a piece in the Upshot that actually posed this following thesis. So why the new blood pressure guidelines could actually lead to harm. And this was an editorial by a professor at, I think, University of Indiana. But his concluding paragraph was that the potential upside for this change is that because of awareness, more people may make lifestyle changes that lead to lower cardiovascular risk in the future. But the potential downside is that more people may receive a diagnosis of high blood pressure, be over-treated with medication, and ensure side effects or adverse outcomes. It's not irrational to fear that these new guidelines may actually lead to more of the latter than the former. So we didn't really need much motivation for what we were going to focus on this year. We were handed it on our laps, a new guideline and an open question. What evidence do we have to support these questions? So I'm just curious, how many people in this room have read the 2017-18 clinical guidelines for hypertension? We got like, I don't say like 20 people here. Okay, so Joe, I see you raised your hand. So did you read the whole thing? No, he didn't read the whole thing, because it actually starts, I love this, it starts with an executive summary. The executive summary is 56 pages, okay? And that executive summary, it does actually list all of the guideline recommendations, but it turns out there's not one guideline recommendation, which is what the mainstream media picked up. There's actually 106 very important and valid recommendations about how to treat patients with hypertension and high blood pressure. Okay? But that's just the executive summary. Actually, I've read it, and the hypertension guideline is pretty amazing. You got an executive summary that feeds into the main document, that feeds into a systematic review, that feeds into supplemental data, that actually provides a tremendous wealth of evidence to back up what has been known. And I can say, honestly, reading this document and not being a clinician and not knowing all that much about hypertension, I found this to be a remarkable piece of scholarship that was put together to actually provide justifications of what there was about these guidelines. And one of the things they do in a guideline is not only do they make these recommendations, but they try to classify the recommendations about what's important. And specifically in this guideline and many others that follow, they talk about the strength of the recommendation in terms of 3 different classes. So there's a class 1 recommendation which is very strong because the benefits far exceed the risks. There's a class 2 or moderate recommendation where the benefits probably outweigh the risks. You also get down to a class 3 where we think there may be no benefit, and there's even a class 3 of harm, that the risks outweigh the benefits. And associated with each of these strengths of the recommendations is a quality of evidence. And they classify the quality of evidence for each one of these guidelines into these categories. There's level A, which is multiple randomized clinical trials have been brought together to provide us an answer. There's level B, where there's at least some randomized, level BR, which is there's some randomized evidence, like a trial. There is level BNR, which is non-randomized work. You can imagine we might fit in there a little bit. There is level C LD, which is limited data. And then there's level C EO, which is expert opinion. Okay? And so every one of those 106 guidelines is actually classified based on how strong is the recommendation and what is the quality of evidence that's actually available. I'm not going to bore you with reading you all 106, but what I'd like to do is showcase at least a couple as a motivation of questions that we think might be interesting to think about the context of where they came from. So in section 8.1.6 of this beautiful document, they specifically talk about the choice of initial medication. And the recommendation that's made in the new guidelines for the choice of initial medication is that for initiation of antihypertensive drug therapy, first-line agents include thiazide diuretics, calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers. Now this is a recommendation of class 1. This is the strongest piece of evidence, or strongest terms of a guideline that we can have. And the level of evidence is an ASR. So it's a systematic review of randomized clinical trials. So this is the best evidence that we've got. And the recommendation ultimately is for initiation of antihypertensive treatments. First-line treatments could include any of these 4 classes of drugs. Notable on this list does not include beta blockers, which that CNN video said, don't worry, you can just be treated with a beta blocker. So let's unpack this a little bit. The guideline and the best evidence we've got says take any of these 4 drugs. So, well, that's a little bit nebulous because we actually need to know what are the drugs. And so in the guidelines, they actually provide in this table 18 a list of all primary agents and secondary agents that can be used to treat hypertension. And so there are 4 thiazide diuretics that are out there. There are 10 ACE inhibitors. There are 8 ARBs. There are 2 different types of calcium channel blockers, and we got 5 of one and 2 of another. So if I were to summarize a little bit about what that clinical guideline says, it says you only have 29 different drugs in 5 different classes to choose from. And so if you are a patient who's been newly diagnosed with hypertension and you're working with your clinician to think about how treatment, you are left with a bevy of options for which the guideline doesn't go any further than just say, take any of these 29 drugs. Now, I would say that that's not nothing because there's a lot of strong evidence to suggest that these drugs are pretty good. And importantly, they distinguished these 29 drugs from the other 28 drugs that are in a clinician's armamentarium to think about managing hypertension, which involves 12 other classes of drugs. And they specifically list these as secondary agents, not specifically recommended for first-line treatment. And in that list of secondary agents was the list of listed was beta blockers. So guideline basically says if you're newly diagnosed with hypertension, choose amongst any of these 29 drugs. So the question that jumped to our mind was, well, how are patients with hypertension actually treated in the real world? And it turns out that maybe George had the foresight about it because we answered that question 2 years ago. As many of you may recall, one of our first OHDSI network studies was characterizing treatment pathways across the OHDSI network. And we previously showcased the work in that paper that related to depression, and we've also looked at some of the work that has been done in diabetes, but we haven't actually talked that much about the results for hypertension. But what this paper actually showed is that across the OHDSI community, we were able to create a cohort of over 1 million patients who had hypertension, had a year of a look-back period, and had 3 years of continuous exposure. And we were able to aggregate results across 11 data sources in 4 different countries. And those of you who remember the fun little sunburst plot, this was the sunburst plot for hypertension. What we saw is the guideline says take any of these 29 drugs, and sure enough, people are taking any of those 29 drugs. There is no one drug that's very obviously being prescribed as first-line therapy, but rather we can see there's a good amount of thiazide diuretic use, there's a good amount of lisinopril, there's a good amount of amlodipine, there's also a good amount of atenolol and other beta blockers that are at the top of this list. So that's what we observed in our paper a couple years ago. And so it became pretty obvious to me, well, that seems like there's a lot of choices to be made. Maybe there's a chance that we could generate evidence that would inform that a little bit. So one of the things, just a random aside, but lots of people loved the treatment pathway paper and thought it was really cool, and a lot of people actually specifically were like, well, how do I do that for my own research? And so a shout out to the OHDSI community and the Atlas development team. There's actually a new feature in our software to do this dynamically in our software application to create cohort pathways. And there's going to be a demo, and we're going to get a clap for that. Yeah, multiple claps for that. There is actually going to be a demo during the collaborator showcase. Chris Knoll will be leading on behalf of the team that developed this. But just to showcase it, I actually used the tool to actually support our understanding of hypertension. But the tool allows us to pick any kind of permutation of things. And so what I did is I actually looked at the classes that were described in the study. And what we actually saw in our data was ACE inhibitors looks like the drug class that is being used most first. We see that there's a good amount of thiazide diuretic being used. The third most prevalent initial treatment is beta blockers, not recommended. And the fourth most prevalent treatment is actually combination therapy, combining an ACE inhibitor and a thiazide diuretic as a combination treatment. The fourth most prevalent choice to make was to start with 2 drugs at once. Okay? I encourage you to check out this tool and see more about this. But the question that really kind of came to our mind was, for the initiation of antihypertensive drug therapy, how should patients be treated? And more specifically, what evidence do we have about the comparative effectiveness of these alternative drugs? Because it's valuable that we can say, probably start with these 29 drugs and not these other 28 drugs, but that still leaves an awful lot of wiggle room about what choices might actually make sense and potentially differentiate choices and help patients make better decisions. And so it made us reflect on, well, what is that evidence that's actually backing up that guideline anyway? They provided a systematic review of all these clinical trials. And what I'm showing you here is we actually took all of the clinical trials from the guidelines, and we just wanted to summarize what is the totality of evidence. And just to orient you to this picture, you can actually see a circle. Hopefully it's coming up okay. There's a circle for each of those first line and second line, primary and secondary agents for hypertension. I've organized them by the various classes. And then if you see a line connecting 2 particular dots, that means there was a clinical trial that provided us head-to-head information about the comparative effectiveness of those 2 products. And what you can see is that this systematic review, it's very exhaustive. I'd say, relative to just about anything else, hypertension is the area we've probably done the most research and we know the most about. And there's actually 40 randomized clinical trials that compare 2 or more of these treatments. And so this is just a picture kind of summarizing, like, this is our state of knowledge, and it's pretty impressive that we have all that knowledge already. At the same time, it's also pretty obvious that not all the questions that we might want to ask have been answered by clinical trials yet. But what do we know? One of the things that was really cool in the systematic review, all the way down, once you click through the rabbit hole to get all the way to the bottom, is they actually provide these network meta-analyses that actually tell us about what trials contribute to what comparisons and what effect estimates we learned on the basis of that. So I'm showing you one of them that's in the systematic review. This is specifically for the outcome of myocardial infarction. And to orient you to this picture, each of these circles represents one of those drug classes. So you've got ACEs, ARBs, calcium channel blockers, beta blockers, and thiazide diuretics. There's an arrow connecting each of these two dots. So ACE inhibitors here is connected to thiazide diuretics. And on that arrow, they list the specific clinical trials that contribute to our understanding, as well as a direct meta-analytic estimate, pooling those clinical trials together to give us an estimate. So if I focus right here, ACEs versus thiazide diuretics for the outcome of myocardial infarction, the systematic review does a great job of telling us that there were 3 clinical trials providing us direct information: ALLHAT, ANBP2, and Phyllis. And when we pooled all that information together, it is our understanding now that the effect estimate is 1.2 with a confidence interval from 0.78 to 2.0. Now, just to orient you to this picture, what this is saying is the target drug is thiazide diuretics, the comparator is ACE inhibitors, and that's the effect that we're seeing. And they did this for every pairwise comparison, pooling the clinical trial data together. So just to dig a little bit further, though, so they said that there was 3 trials, and you got this composite estimate of 1.2 with a confidence interval from 0.78 to 2.0. But we thought, well, let's actually look at those clinical trials that contributed to this particular estimate. And so what we could see is there were 3 trials. There's the ALLHAT trial. The ALLHAT trial is one of I'd say, our biggest accomplishments in cardiology. It's a tremendous trial that we learned an awful lot about antihypertensive treatments. But specifically to explain for those who aren't familiar, this was a study that compared the drug chlorthalidone versus the drug lisinopril. And there was roughly there's 15,000 patients randomized to chlorthalidone and about 9,000 patients randomized to lisinopril. And this study specifically, though, was patients who already had hypertension, who were previously treated, and who had at least one cardiovascular disease risk factor. Okay? So these are already people with hypertension, have some other effect going on, and it was a large-scale study. And in that study, they specifically produced an estimate of relative risk of 1.01 with a confidence interval from 0.93 to 1.1, basically observing no statistical difference. Now, the ANBP2 study, which was also mentioned, this was a study that randomized about 3,000 patients into 2 arms. They compared the drug hydrochlorothiazide versus the drug enalapril. And specifically, this was a study in Australians over the age 65 who had a systolic blood pressure greater than 160. And 62% of these people were previously treated. And in that study, they actually did observe an increased risk associated with hydrochlorothiazide with 1.47 in a statistically significant confidence interval. And that third study that they highlighted, the Phyllis study, this was a study of Italians, 45 to 70 years old, who had to have both hypertension and hypercholesterolemia. And in that study, there was about 100 people who were randomized to the drug hydrochlorothiazide or the drug fosinapril. And this study was so small, they couldn't even report an estimate for the outcome of myocardial infarction. So just to unpack what we've got this comparison of ACE inhibitors versus thiazide diuretics built up based on the totality of knowledge we've got from clinical trials. And we've got one trial really driving our knowledge because ALLHAT was an impressive study, but it is not a study in initiating hypertensive treatment. We've got a second study, ANBP, using different drugs than ALLHAT, also not in patients who are starting treatment for hypertension. And then we've got a third study with people with multiple comorbidities that wasn't big enough to actually provide us an estimate. That is our current totality of randomized trial knowledge about this one particular question. So shifting gears just a second, when we think about using observational data, there's a lot of opinions about causal inference and what we could actually learn from an observational study. And there's been some really nice work that's been led by Miguel Hernan and Jamie Robbins that have talked about how do we apply best practices for causal inference as we would design clinical trials and bring that into our understanding of how to study observational data sets. And so one of the things that Miguel has actually preached many times for the last several years is this idea that maybe to design an observational study, you should emulate a target trial. Basically, come up with the perfect trial that would answer your question, and then think about how well could you design an observational study to do that. So that got us thinking, well, what would be the target trial to actually support this guideline? What would that design look like to actually help provide more informative evidence than those 3 trials I just listed? And it's my positive opinion that randomization would be the key to a target trial. We want to be able to have that emphasis. But at the point of randomization, if we are trying to produce evidence to support what should be the first treatment you take after being newly diagnosed with hypertension, we should recruit people who are newly diagnosed with hypertension who haven't been treated with other drugs. And so what that would mean is we want to have people who are newly diagnosed who don't have any observation of prior treatment. And that provides our time 0. And at that time, we would like to randomize those people. And if we're doing a head-to-head study, that means we'd randomize them to monotherapy for ACE inhibitors or monotherapy for a thiazide diuretic. Now, Miguel talks about the other dimensions we need to think about, and he talks about you specifically need to be careful about follow-up time and the causal contrast that you're going to study. So clearly, in an ideal world, we're going to be studying patients who are taking hypertension. We're trying to avert cardiovascular outcomes. So we would like to follow people as long as we could, but there's really 2 causal contrasts that might be interesting. There's the idea of an intent to treat analysis, where we're just going to look for events after this randomization event. And there's also the notion of an on-treatment effect, where so long as they stay on the treatment that they were randomized to, we'd like to see what that effect would be. And I think both of those causal contrasts are valid. And specifically, since the guidelines focus on the efficacy outcomes, we would think that a target trial should study outcomes such as myocardial infarction, stroke, and heart failure. These are kind of the typical cardiovascular outcomes that we see and were measured in all of those other clinical trials. And so basically the analysis plan that one would conduct in this idealized target trial would be a time to first event analysis, and we'd probably run a Cox proportional hazard model to basically say ACEs versus thiazide diuretics, which drugs has differential hazards of experiencing a myocardial infarction or a stroke or a heart failure sometime in the future. So this is kind of our idea of like what would be an idealized target trial. And as we reviewed the clinical trials that are available that actually are supporting this guideline recommendations, what was very notable is we didn't see any trials that specifically were conforming to what we think would be idealized. And it makes perfect sense why this is. Designing this study would probably cost $100 million. And that would only answer one question for one comparison of two classes. So it's almost inconceivable to do what's the ideal. Okay, but let's just say that, all that's pretty good. Let's assume that that information that came from those studies is close enough to the target trial. So that means, let's trust that these numbers are actually right in some capacity. So we're left with an effect estimate of 1.2 with a confidence interval from 0.78 to 2.0. And that's our current state of knowledge. So we've been thinking a lot about how to actually interpret that information now that it's actually been generated and provided. And so I'm just going to show this to you like as in a forest plot. Basically, you'd get this confidence interval. And what you'd say is if you see a value to the left of 1, that would be an effect that favors the thiazide diuretic. If you saw an effect to the right of 1, that would be an effect that favors the ACE inhibitor. And we're left with this confidence interval that goes from 0.78 to 2.0. So this is the interactive portion of the day. I need you to stand up if you think that this effect estimate shows no statistically significant difference. All right, so some of you, stay standing. So some of you think that this confidence interval that goes from 0.78 to 2, some of you have stood up and you think that this is not showing a statistically significant difference. And it's only about, like a third of you stood up to this question. And the other 2/3, that means that you think that this is showing a statistically significant difference. Okay, so there's a little bit of uncertainty. This is shocking to me. I was not expecting this, so we're going to go with this. This is awesome. Okay, so those of you who are standing, I'm going to ask you, those of you who are standing, I'm going to ask you a second question. I want you to sit down if you think that this effect estimate suggests that the expected average treatment effect is a 20% increased risk for hydrochlorothiazide. Basically, is the point estimate 1.2? If it is, you can sit down. So people are standing. So, okay, this is great. Okay. So, all right, this is already very informative to me. We struggle as a community to interpret statistical artifacts. I can say that what this confidence interval does, by virtue of the fact that it covers 1, that means that there is not an observed statistically significant difference. So I was kind of expecting people to stand up because that was not a statistically significant difference that is observed. But I was also expecting all of you to sit down because the point estimate of this is 1.2, and that suggests that the expected effect is a 20% increase. Okay? So you guys can sit down now. Okay, so we're going to do one more test, though. Now that you're all seated, I want you to raise your left hand. Remember which one is left and right. I always struggle with that. Raise your left hand if you think that this estimate suggests that the risk associated with thiazide diuretics versus ACEs could be as large as a 100% increase, meaning the relative risk could be up to 2. Raise your left hand. Does that confidence interval get to the number 2? Okay, so about half of you aren't raising your hand. Okay, so we're not sure about that. Okay, that's interesting. Raise your right hand. So you got your left hand up for those of you that. Raise your right hand if you think that the estimate suggests that the risk associated with thiazide diuretics and ACEs could be as large as a 28% decrease, meaning does that confidence interval go all the way to 0.78? What's that? No, it's not 22 because it's 1 over. 1 over, so it's 22. Okay? All right, so some people have got both hands. Some people maybe aren't even interested in this question, but that's okay. I'm interested, and that was actually a great exercise to learn. You guys can put your hand down. Thank you very much. So here's the interesting aha that we had when looking at this is that the evidence we have actually could mean an awful lot of different things. So To get into that, we'd think, well, what if there was new evidence? What if that target trial, that is the ideal study we wanted, actually produced an effect estimate? How would we interpret that now that we already have the meta-analysis estimate? And so there's a few scenarios that could play out. One scenario is we could get a new estimate that is fully overlapping. So meaning the confidence interval of the new estimate is inside the confidence interval of the systematic review, which basically means the studies are fully concordant, but maybe we've learned a little bit more by making that confidence interval a little bit narrower. There's another extreme situation is we could have something totally discordant. So imagine we conducted the target trial and the new effect estimate was a confidence interval that was totally outside of the original confidence interval. We'd be in a real pickle in that situation because we'd have two things that are totally discordant. There's also a little bit more of a nuance, though, that you could also have something like partial overlap. A confidence interval that is mostly contained by what we learned in the clinical trial, but maybe the edge of that confidence interval crosses outside. And it turns out, just in basic statistics, that when you have partial overlap, sometimes that difference is not statistically significantly different, meaning you still would judge those two studies to be concordant. And sometimes you would actually have something that is statistically significant different, even though there's some overlap. And so those two scenarios could play out. So we're really in a pickle that if we were to do a target trial and generate new information, we're going to have to then reconcile what do we do with this new information to put it alongside of what we already know. So let's think about some scenarios that could play out if we conduct the target trial. So here's a what if number one. We could do the target trial, and it could give us an effect estimate that provided a point estimate of 1.2, but now the confidence interval goes from 1.1 to 1.3, meaning it's statistically significant. Totally concordant, fully overlapping, but now we go from saying there was no difference to now suggesting that ACE inhibitors are better than thiazide diuretics. That could totally happen. Another scenario that could play out would be that the target trial produces a relative risk of 1 with a confidence interval from 0.9 to 1.1. This would be fully concordant. It's totally overlapping in the trial, and yet this study would suggest there is no statistically significant difference. And with that tight confidence interval, we actually feel like we're starting to learn that probably there isn't actually a difference. Or if there is a difference, it's very small in size. So that could totally happen. You could also end up with, because of this original confidence interval, we could actually get an effect estimate of like 0.8 or 0.85 with a confidence interval that goes from 0.8 to 0.9. It's actually possible that we could have a fully concordant study that's non-significant overlap, and yet we would actually conclude that thiazide diuretics are better than ACE inhibitors. We could also end up in a situation where the point estimate is even larger from our target trial, and we could end up in a situation where the effect estimate may be like 1.7. All of these scenarios are completely plausible to occur, given that our current knowledge is from 0.78 to 2. It means that if we did the idealized study, we might show no difference. We might show that ACE inhibitors are better than thiazide diuretics. We might show that thiazide diuretics are better than ACE inhibitors. We might show that the effect is big. We might show that the effect is small. All of these things could happen if we generated new evidence, and we would say we've done a new study that is fully concordant with what we already knew, and yet now we've gained new insights because we now can say, instead of we don't know if there's a difference, we'd be able to say there is or isn't a difference. So be sure it'd be nice if we could do that target trial. Now, turns out that one example I just showed, ACE inhibitors and thiazide diuretics for myocardial infarction, this systematic review evaluated the current knowledge of everything. And what they showed was for myocardial infarction across every one of those pairwise comparisons, they did not observe a statistically significant difference comparing any of those drugs. So basically that scenario of a wide confidence interval where it could be small and it could be big or it could be nothing, for all of those comparisons, the answer was we don't know. For stroke, when they looked at all those comparisons, they found one statistically significant difference. They showed that ARBs have a lower risk of stroke relative to beta blockers. For all of those other pairwise comparisons, could be smaller, could be bigger, we don't know. For heart failure, when they conducted this direct meta-analysis across all those, they found one statistically significant difference. They showed that calcium channel blockers reduce the risk of heart failure relative to thiazide diuretics. Everything else could be bigger, could be smaller, we don't know. What's even more revealing to me is they then conducted a network meta-analysis to try to pool evidence indirectly from across this network, and they found a couple more significant findings, the most notable being that they concluded on the basis of their network meta-analysis that beta blockers really do look like a worse product for a worse class of drugs for the outcome of stroke. And on the basis of this network meta-analysis, this was basically the reason why beta blockers dropped off the list of primary agents. But if we look across these estimates, we actually see that 8 out of the 10 meta-analysis estimates couldn't rule out the possibility that the drugs have a twofold difference, even though they were not statistically significant. And in the case of stroke, one of those comparisons could not even rule out a twofold difference. And for heart failure, 4 out of 10 of those comparisons could not rule out a twofold difference. Meaning, our current state of knowledge is we don't know what the effect is, but the effect might be a doubling of the risk. And when I saw this and I thought about what this means, it means that we've got a huge opportunity because it sure would be nice to be a lot more confident than it's possible that these drugs double the risk of heart attacks and strokes and heart failure. So, I'm doing okay because of the next time. Okay. So that's humbling and it presents a big opportunity. Now let's go to guideline recommendation number 2. So recommendation number 2 that they actually outline is the recommendation for the choice of initial monotherapy versus initial combination drug therapy. And specifically, they say that initiation of antihypertensive drug therapy with 2 first-line agents of different classes, either as separate agents or in a fixed-dose combination, is recommended for adults with stage 2 hypertension. Now, this was a class 1 strength of recommendation, meaning this is the strongest thing where they believe the benefits far outweigh the risks. And the level of evidence is expert opinion. So we're making a pretty strong statement here. Patients who are newly diagnosed with hypertension that need to get a first drug should start immediately on 2 drugs based on the clinical consensus of this community. And they highlight the challenge that they face. This may very well be a very good recommendation, but the reason why it's expert opinion is because there are no clinical trials that have actually answered this question. Sure, we've learned a lot of things about step-up therapy in hypertension. We've learned that generally 2 drugs work better for managing blood pressure than upping the dose of 1 drug. But there has never been a clinical trial that specifically said, let's compare 1 monotherapy, take patients who are newly diagnosed, and either randomize them to get 1 monotherapy or to get a combination therapy. And so on the basis of this, the guideline is actually saying, you really should give 2 drugs, we think. So what would that target trial actually look like if we were to get another $100 million and be able to design a clinical trial that answered the question? Well, as we thought about it, we realized that all the same choices I made to compare 1 monotherapy versus another monotherapy, we'd make the same choices. The only difference would be that now instead of randomizing to 2 arms, I'm going to randomize to 3 arms. We'd have some people who would be randomized to monotherapy on ACE inhibitors, another group that would be randomized to monotherapy on a thiazide diuretic, and then a third group now would be randomized to get the combination pill of ACEs and thiazide diuretics. And so that means with this 3-arm study, we'd be making 2 comparisons. We'd be comparing ACEs alone versus ACEs plus thiazide diuretics, and we'd be making the comparison of thiazide diuretics versus ACEs and thiazide diuretics. So if we had $100 million, we could probably do this study, and it would be useful because we could actually fill the gap that currently says we're just basing this on expert opinion. So if anybody's got an extra 100 mil, come talk to me. The thing that's also notable about this, though, is when they talk about like why to make these treatments, one of the cautionary tales in the expert opinion is we think this should be better for the efficacy, meaning the reduction of cardiovascular effects from myocardial infarction, stroke, and heart failure. But there's some concern or caution about the fact that these drugs actually have side effects. And so if we were to get an extra 100 million on top of the first one, we might actually collect more data about the patients. We might not just study cardiovascular outcomes as the benefits, but we might also simultaneously collect information about what are known side effects of these drugs. We know that ACE inhibitors cause angioedema, but we don't know whether an ACE inhibitor by itself causes angioedema more or less than a combination. We know that these drugs actually have effects of acute renal failure, but we don't know which one of these treatments is better. We know ACE inhibitors cause cough. We know that these drugs actually can cause electrolyte imbalance, but we don't know how they compare to one another based on any sort of target trial. So I think that's a pretty big opportunity. If we could actually provide some evidence that would actually inform something, and we could take a guideline and take it from expert opinion to data and evidence that could actually support that, potentially those millions of people who are newly diagnosed with hypertension, we could help them. So there's some other questions, though, that this guideline raises, which I think are pretty fascinating. One of them is everything discussed in this document is talking about classes of drugs, ACEs and ARBs and calcium channel blockers and thiazide diuretics. An open question that I have is, are the drugs in the class actually equivalent? The trials don't actually, when I showed you the list of trials, none of them were head-to-head comparisons of two drugs in the same class. They were always comparing two drugs in different classes. And yet, in that table that I showed you earlier, one of the things that's a little interesting little side note nugget in the slide here is when they talk about the class of thiazide diuretics, they provide this bullet that says chlorthalidone is preferred on the basis of a prolonged half-life and a proven trial reduction in cardiovascular disease. Now that proven trial reduction, that's ALLHAT. ALLHAT happened to choose the use of chlorthalidone in their study, and on the basis of a very impressive study that we learned a lot from, people started to be like, yeah, maybe chlorthalidone should be the drug we use. Though I showed you in our treatment pathway, chlorthalidone is actually not used very much as a thiazide diuretic. Hydrochlorothiazide is dominating as an individual drug in this class. Well, it turns out that this question, this open residual question, are drugs the same? This is actually something that people are worried about. So how would we do that study? Well, we could design a target study, and lo and behold, it'll look just like the target studies we've answered previous questions for. The only difference would be instead of comparing two classes, we would randomize people to an arm of chlorthalidone and compare them to a randomized arm of people with hydrochlorothiazide. Again, we'd want people who are treatment naive, who are newly diagnosed, and they'd go on, and we could study all the same outcomes that we had built up there before. Well, it actually turns out that this question matters enough that our friends at the Department of Veterans Affairs are conducting a randomized clinical trial on this question. The Diuretic Comparison Project was initiated back in 2016, and it's like a $10 million study that's going to be running for several years that is actually specifically trying to provide us evidence about whether chlorthalidone is better or worse than hydrochlorothiazide. Now, in their design of this study, they took patients who are already taking hydrochlorothiazides. They're already on a hydrochlorothiazide for some period of time. And then if they enroll in the study, they will be randomized to either stay on their hydrochlorothiazide or they'll be randomized to switch to chlorthalidone. And then they're going to follow people for about 3 years. They're going to look at some of these cardiovascular outcomes, and they hope to report out knowledge that'll help answer that question in the guideline that's screaming out for an answer. This study, once done, if they hit their targets, will recruit 13,500 patients. It kicked off in 2016, and we can expect that we will learn something in 2022. So hopefully those 13,000 patients give us the knowledge we need to help inform patient care. Question that I wonder, though, is what could we learn now from observational data while we wait 4 years for this trial to report out? Maybe we could give the VA the answer so they could know what to look for when they finish their study. So to summarize the opportunity, when we read this guideline and we were thinking about how can the OHDSI community make an impact, how can we help patients make better health decisions, we read this guideline. It's one of the most tremendous pieces of scientific work. It represents the totality of our current learning healthcare system, and yet we look through this document and all I see are gaps. I see opportunities. I see really exciting situations where we as a community could actually help the millions of people who are now being newly diagnosed with hypertension to hopefully live better lives. Here are some things we could do as a community. Well, first of all, there's an awful lot of that level of evidence that's level A. It's from clinical trials. Is what we observed in clinical trials actually happening in the real world? I'd like to know that. We got a bunch of recommendations that are based on expert opinion. Could we provide data to support those expert opinions? Or potentially answer the question and learn something new so that we're not just based on expert opinions? I think we could do that. If we're going to have a guideline that says just take any of these 29 drugs, I wonder whether we could actually enable greater specificity in the guidelines to take comparative effectiveness and comparative safety data and say more than just take any of these drugs, but instead say which drugs we should take based on their comparative profile. And I think we could do that. And I also think, as we went through that exercise of reconciling uncertainty, we have data right now that has tremendous uncertainty. We also clearly demonstrated that understanding uncertainty is super hard. So if we as a community could just reduce uncertainty to fill the gaps with more concrete knowledge, that could potentially impact clinical practice and improve the lives of patients around the world. But all of this is based on clinical trials because we know clinical trials are the best kind of evidence. They are also, and what I've provided you is an idealized world of what a target trial would look like, but no matter how many people I ask, nobody gives me $100 million to conduct a 10-year study. I'm just not persuasive enough, I guess. Really, the real challenge is that most people don't trust observational data at all. So if we've got all these clinical trials and providing really definitive evidence, how are we possibly going to then nudge observational data into this conversation? And part of the justification for that is that we haven't done a good job as a community of proving that the evidence that we're generating is actually worthwhile and credible. And so probably before we can answer this clinical question, we need to start by saying, how are we going to generate evidence that's actually going to be credible and trustworthy and be positioned to possibly contribute to the guideline? And so I think there's a big opportunity. I recognize the giant challenge. And now Martijn is going to talk to us about how we could think differently about generating evidence, evaluating that evidence, and disseminating evidence to impact hypertension.
All right. Well, thank you, Patrick, for that introduction. So I know that a lot of you frequently visit the OHDSI forums. And so I know that probably many of you have seen this paper that was posted by Chan on the forum that I think is a very important paper. What was discussed in this paper was evidence for treatments of heart failure, both from randomized trials and from observational research. And what the authors did, I think was a very good effort, is they looked at whether or not there was agreement between what was observed in those randomized trials and what came out of those observational studies. And what the authors found was, time and again, there was rather sharp disagreement between the observational studies and the randomized trials, even extreme situations where the confidence intervals from the trials were completely disjoint from the confidence intervals of the observational studies. And I think I agree with the authors. I trust the randomized trials more than I do the observational studies. And so that led them to this rather harsh judgment in their title, saying that treatment effects cannot be estimated from observational data. And that's a pretty damning statement, but I actually agree with them. What is the problem with observational data? Why can we not rely on it? So the authors here, Russian colleagues, point their finger at residual confounding. So they observe that in a randomized controlled trial, because of randomization, we can directly observe the effect of the drug on the outcome. In a non-randomized study, we have the problem of confounders, and we know that, so we typically try to adjust for those confounders, but there are always either unmeasured or unknown confounders that we cannot adjust for, and therefore the results from these observational studies are biased. Again, I think the authors are right in that this is a problem, but I think there is another problem, maybe even a bigger problem, and I actually talked about that problem when I was at this very symposium 2 years ago. The plot that I showed you then is this plot, and so let me walk you through what you're seeing. On the x-axis, you're seeing the effect size from a study. So that can be a hazard ratio or an odds ratio. And on the y-axis, you see the standard error, basically the width of the confidence interval, the uncertainty in a study. Each and every dot that I'm showing here is an effect size estimate from an observational study, as I automatically extracted it from a PubMed abstract of an observational study. So this is, you can think of this as what we've learned and published about observational research. Even though this plot is showing a lot of different estimates from very different types of studies, studying different exposures and outcomes, there is a very clear pattern here for you to observe. And I've highlighted that pattern by drawing that red dashed line, and that dashed line indicates where the p-value is equal to 0.05. Everything below the dashed line is statistically significant. And I think you'll agree with me that there is this very suspicious cutoff at exactly that line. What that cutoff is telling you is that there is a lot of publication bias and p-hacking going on. And what is important about that is that both of those things tend to lead to large numbers of false positives. So publication bias doesn't just hide things from you, so hides things that you might want to know. It also, because there's hidden multiple testing going on that you can't see, it leads to the things that are shown have a very high probability of being false positives. So individual studies are prone to residual bias due to confounding, selection bias, and measurement error. And this problem is exacerbated across studies by publication bias and p-hacking. And this is a very serious problem. And if I look at myself personally, I have lost faith in published observational studies. If a news outlet like the BBC is coming out with a report of a new study, observational study, that is showing some spectacular effects of some drugs causing dementia, I just roll my eyes and think, oh, here we go again. I don't believe what that is. And that puts me in the same camp as Russian colleagues that wrote that paper, saying we just can't believe observational research. And that is pretty bad, because that means that there is a large source of information that I can't use because I don't trust it. Then there is the other camp that does believe observational data, and I think that they're quite often being misinformed and thereby may make wrong medical decisions and maybe put themselves in harm's way. And so none of this, I think, is acceptable and is something that we need to solve. So what can we do to solve this? Well, the most obvious thing is, well, let's try and develop methods that deal with confounding in a better way. And so one such method was developed within OHDSI, where we start by constructing a large set of covariates from the data. So if we're going to compare people taking different treatments, we can construct baseline covariates of things that happened to them in their past. And we construct any type of covariate that we can think of. So any condition, any drug, any procedure, but also condition groups, drug classes, any demographics, all of them, as far as we observe them in the data, we turn them into a variable. And typically that leads us, depending on the data that we're looking at, to somewhere between 10,000 and 100,000 variables that we can put into a model. And we put that into a large-scale propensity model, and we use regularized regression to be able to fit such a complicated model. We can then match or stratify on the propensity score. And what we've observed in quite a few studies where we've applied this approach is that that achieves balance on all the covariates that we look at. So in this particular graph that I'm showing, on the x-axis is the standardized difference of the mean before matching. And you see that the two groups that we were looking at were very different in quite a lot of different ways as we measured using these variables. But if you look at the y-axis, which is the standardized difference of the mean after matching, you see that we've been able to correct for pretty much all of those differences. And usually we use a cutoff of 0.1 to say, well, anything below that, we believe we are balanced on that. And so we've achieved balance on all 58,285 covariates that were used in this particular study, meaning that in every way that we can think of, these patients now look the same, and we're basically back to what we hope is the ideal randomized trial. And so not too long ago, Yuxi Chen from UCLA published a paper about this method and evaluating it and comparing it to existing methods and showing the merits of this approach. And this was just published in the International Journal of Epidemiology. So it's good that we have good methods for dealing with confounding, but I'm sure you'll agree with me that we can't just blindly trust that this will solve all of our problems. We need to make sure that it does. And so we've also come up with this idea of measuring residual bias. An observational study is basically an instrument for measuring an effect size. And like any instrument, like a scale that is an instrument for measuring weight, we can look at the accuracy of that instrument. And so for a scale, you can measure the accuracy of the scale by putting objects on the scale that you know the weight of and see whether the scale actually reproduces that weight. And so for observational studies, we use control questions, which is typically exposure outcome pairs where we know what the true effect size is. And often we have negative and positive controls, where negative controls are research questions where we know the true effect size is a null effect size, and positive controls where the true effect size is of some known magnitude other than null. And so we can apply our study to those questions and see whether they actually produce results that are in line with the known truth. If you do this for a scale, you often have the option to then calibrate your scale based on what you observed for your objects of known weight. There often even is a small button on a knob that you can turn on your scale. And we can now do the same thing for observational studies. So based on what we observed for our control questions, we can calibrate our p-values and our confidence intervals using the effect size estimates of these control questions. And so we also this year published this paper, already highlighted by George, in PNAS, where we demonstrate confidence interval calibration using this very approach. So using the method described by Yushi to try and deal with confounding as much as possible, and then using this approach to learn how much residual bias was left and try to calibrate for that, that's something that we recommend that we should do in any study where we generate evidence. But now we still have to solve publication bias and p-hacking. And so this is not a problem that we noticed by ourselves. There are other people that are aware of this problem and have proposed solutions. So one of these solutions is you need to fully specify your protocol beforehand. You need to pre-register your study. And you need to use an open science approach where you're being completely transparent about everything you're doing. I firmly believe that OHDSI is at the forefront of adopting all of these solutions, but I also believe that this is not enough. We need to do something more to make observational research reliable. And so the thing that I proposed again 2 years ago is large-scale studies. And so what I showed then was this proof of concept where we looked at depression, and we looked at depression treatments. We identified 17 treatments for depression, and we made every possible pairwise comparison between depression treatments, so that's 272 comparisons. And we identified 22 outcomes of interest, such as stroke, suicidal ideation, insomnia, etc. Combined, that led us to formulate almost 6,000 research questions that we wanted to answer for depression. As mentioned before, we should always include negative and positive controls, so we added an additional 56,000 control questions, and all of those were processed by our standardized methodology for generating evidence, in this case a new user cohort design using these large-scale propensity scores and fitting Cox proportional hazard models on the stratified data. Thus producing a large set of effect size estimates, which we could then apply empirical calibration on, leading to 6,000 calibrated estimates. We ran this in multiple databases. We didn't have power for all of these questions, but we ended up with 17,718 hazard ratios estimates, together with their full diagnostics, including evaluation of systematic error. And so this plot, just like the plot before, is showing all of these results, all of these estimates. And I think you'll agree with me that the distribution that you see here is very different from what is observed in published literature. This information does include information on small effect sizes. We have assessed study bias using the negative and positive controls. And also, it's very hard to do p-hacking when you're answering 6,000 questions. And we're also not filtering these results based on whether or not they're statistically significant. So there is no publication bias here. So I believe that doing research this way will lead to much more reliable and certainly much more reproducible evidence that we can use to inform medical decision making. So in August of this year, so 2 months ago, we published a paper in Philosophical Transactions where we outlined this approach, arguing that that's the way that we should do research. We not only published this paper, we also made all of those 17,718 estimates publicly available on the web in an application that allows you to explore this evidence and review all of the diagnostics that we provide for each of these estimates. So we have an idea of how we think we should do research, but having an idea by itself isn't good enough. That's not going to help anybody. What we need to do is we need to actually apply that to real problems. And so that's where legend comes in, or large-scale evidence generation and evaluation in a network of databases. So the goal of legend is to apply best practices at a large scale to answer relevant clinical questions. Our hope and our vision for legend is that it will be somewhat similar to, for example, the Large Hadron Collider. And what I like about this photo is that it's showing a lot of scientists that probably otherwise would have just be all of them themselves, by themselves, doing little bits of research and publishing one paper at a time. And instead, they decided to come together to define and build the process that generates the evidence. And so I'm hoping that in legend we can do the same. That as a community, we can come together to define and build a process that generates the evidence. And so we started with legend by first defining some guiding principles. And I'm showing here the 10 guiding principles. I don't have time to go over all of them, but some are fairly obvious, like evidence will be generated by consistently applying a systematic approach across all research questions. So we're not going to do ad hoc decisions. Everything has to be according to some pre-specified plan. Or the evidence will be generated using open source software that is freely available to all, which fits, of course, perfectly in Odyssey's open science philosophy. Such an evidence generation system consists of 3 components. We have to define a set, hopefully a large set, of research questions. Then we have to define the methods by which we will answer those research questions. And then we have to have a set of databases on which we can run the methods to answer the questions. So let's look at that first component, research. All right, research questions. So previously in our proof of concept, hello? We're back. Phew. Previously, we focused on research questions for depression treatments in our proof of concept study. This run, as Patrick already alluded to, we're going to focus on hypertension treatments. Patrick also told you about the target trial, the ideal trial that he would like to do to answer some or a lot of questions that we still have about hypertension treatments. And he also said we can't actually do this trial because that's going to be very expensive. What we can do is we can do an observational study that tries to approximate this trial. And basically the largest difference between our observational study and this trial is going to be we can't do randomization. So we'll have to observe what people did, and that means that people are going to be different. And we'll have to adjust for those differences. But for that, we can use our propensity score adjustment approach. Aside from that, our observational study will be completely identical to this ideal trial that Patrick tried to describe. And so in this trial, we can now compare any treatment for hypertension to any other treatment. And so what are those treatments that we could compare? So here I've drawn a diagram, basically another sunburst plot, but I've only shown one ring because we're only going to look at the very first treatment, the first line therapy that people receive for their hypertension treatment. So people that have newly been diagnosed with hypertension, they start on a wide variety of treatments. And so the ones that I've highlighted here in color are where they start on one drug and one drug only, or you can refer to that as monotherapy. And so you see that there's actually quite a large list of monotherapies to choose from. In fact, we identified 58 ingredients of interest, so drugs of interest that we would like to look at. In our data, we only observed 39 of those with sufficient sample. And so we defined that as having at least 2,500 people on those drugs. With those drugs, in theory, we could make 3,306 comparisons between individual ingredients. But again, due to data constraints, we can only make 1,296 comparisons in our observational study. And we did the same thing at not just the individual drug level, but also at the class level. Patrick also talked about this trial for comparing monotherapy to duotherapy. And so similarly, we can mimic that trial using an observational research design where we don't have the randomization, but we will rely on our propensity score adjustment instead. And so some of the people don't start on a monotherapy. Some people directly start on 2 drugs. And so here in color, I've highlighted what I call the duotherapy that people start on. And just to be clear, these are people that's starting on 2 drugs, not 1, not 3, 2 hypertension treatments. And so we've observed only 58 of those combination therapies that people start on, and that allowed us to make, when we're comparing monotherapy to duotherapy, we can now make 3,810 comparisons in the data. Same for at the class level. But now that we have these duotherapies, we can also compare duotherapy to duotherapy, leading to another 2,784 comparisons that we can make between treatments. And so the grand total of comparisons that we can do in an observational study is 10,278 comparisons between first-line hypertension treatments. But just because we have the data to make these comparisons doesn't mean that all of them are really a good idea. So what I'm showing here is a plot for the IBM CCAE database, where just for the individual drug level, so not the class level, but the ingredient level, we're listing all of the treatments that were observed in that database, so both monotherapy and duotherapy. And each and every plot is showing the propensity score distribution for a comparison of one of those treatments to any of the other treatments in that database. So just to give you a little bit of an idea of what's in there. So for example, this comparison between doxazosin to terazosin, the propensity scores actually overlap almost perfectly. So it's almost as if somebody already did a randomized trial here. These people looked very similar in terms of their baseline characteristics when they started these drugs. And it's almost like somebody just flipped a coin to decide whether they got one drug or the other. So that's certainly a comparison that we can do with confidence in our observational data. Other comparisons, like this one between hydrochlorothiazide and lisinopril, we see some more separation between the distributions, telling us that there is some difference between these 2 population groups, but there is also quite a large amount of overlap between these 2 groups. And so we have quite a lot of confidence that with our propensity score adjustment, we can actually adjust for the observed differences and still make these groups comparable enough to do an estimation study. And then there are others like these furosemide versus amlodipine, where the distributions are completely disjoint. And so based on their baseline characteristics, these people look nothing like each other. We can very easily predict who gets furosemide and who gets the amlodipine. And this is telling that probably even with the best intention and the best adjustment based on propensity scores, we cannot make these groups comparable enough to do a study. Now this is the estimates, the propensity score distributions from one database, the CCAE database. But of course, we're looking in OHDSI at multiple databases. So I would like to invite the people already in position to unveil the posters that we've made. So we've generated this plot in multiple databases. What we've done is we've picked 6 of those databases, the largest ones, and we've printed these plots for those databases at the ingredient level and at the class level. And so these posters are showing you basically all those 10,000 comparisons that I mentioned, which ones have a good overlap and which one don't have an overlap in that database. And just to give you an idea of the magnitude of what we've done here, so each one of these is done using these large-scale propensity models where we have somewhere between 10,000 and 100,000 variables that go into the model. And a lot of these comparisons have at least 10,000 subjects, and some of them even have millions of subjects in them. And so we did that across all these databases for all these questions. And so I would invite you in the break to maybe look at these posters, and if you have a particular comparison in mind that you're interested in, you can look at whether or not a particular database has sufficient overlap for that question. All right. Oh. All right, so now we have our target trials all set up. Now, of course, we have to think of the outcomes that we're going to be looking at for those comparisons. And so we identified 58 outcomes of interest. Some of those are the efficacy outcomes that were also considered in the guidelines and in the systematic review. And some of these are safety outcomes that are discussed either in the guidelines or most often in the product labels of these products. And so, seeing as we started with 10,000 comparisons, that led us to 587,020 target comparator outcome triplets, or basically fully specified research questions that we aim to answer in Legend. So 500,000 research questions. But, as already mentioned before, each one of those we have to apply best practices. So that means that we need to evaluate propensity score distribution. We need to evaluate covariate balance. We need to include negative and positive controls. And we need to possibly use those for empirical calibration. And so in order to do those last two things, we need to define a set of negative controls, which we did. In this case, we have 76 negative control outcomes. So these are outcomes where we firmly believe that none of the hypertension treatments causes any of the outcomes. And therefore, if we make a comparison between two treatments, the hazard ratio, the true hazard ratio, should be equal to 1. And so we can test whether our approach actually, our study design produces these effect size estimates that we know to be true. We've also developed a technique to turn these negative controls into synthetic positive controls in a process that's described in our PNAS paper. And so in total, we have 1.4 million control questions that we need to also produce estimates for in order to get some sort of a confidence, or at least a knowledge of the accuracy for our 500,000 questions of interest. So those are the 500,000 research questions of interest and 1.4 million control questions that we want answered in this round of Legend. Now let's briefly talk about the methods. Well, the method we already talked about a little bit. We'd like to emulate this ideal target trial. So that means we'll be using a new user cohort design. The outcomes will be measured using expert-defined outcome definitions. So just to make the point, this isn't just simple occurrence of codes that we're looking at. We had experts define all of these outcomes and how to detect them in the data that we were using. We used the large-scale propensity models that I mentioned earlier, stratification and variable ratio matching on these propensity scores, a Cox regression model, and we applied empirical calibration using these negative and positive controls. So that's what we used this time. That's not not cast in stone. That's not static. But what is important to realize here is that the choice of the method that we apply in Legend is driven by defined best practice. And what is defined best practice, in turn, is driven by empirical evaluation. And so last year, I actually had 2 posters describing the efforts in OHDSI to empirically evaluate methods within observational research using an empirical design. Last but not least, we need to have a set of databases. And so in our original proof of concept for depression, we used 4 US insurance claims databases. And this time around, we used, again, those same 4 databases, but we also used a Japanese insurance database, a Korean national insurance database, 2 US electronic health record databases and 1 German electronic health record database. And I would like to express my gratitude especially to IU University and to Columbia University, who not only provided access to their data to participate in this study, but also provided the computational resources to run it on their data. As you may imagine, running a study like LEGEND is not trivial in terms of computational expense, so I'm very grateful that they were able to run it in their infrastructure. All right, so now I've defined an observational research experiment of quite large scale, but as I mentioned before, LEGEND isn't just about thinking what would be a good idea, it's about actually doing it. So, of course, we actually ran the LEGEND study. So what I'm showing you here is, again, similar to the plot I showed earlier, but now the calibrated estimates that were produced in LEGEND for these 500,000 research questions that we defined that we wanted answers to. And because we ran it across multiple databases, we now have 1.3 million calibrated hazard ratio estimates with full diagnostics that we can explore. Now the question is, now that we have all this, how are we going to disseminate that? How are we going to make sure that this has impact and people start using it to inform their decision making? Well, we already are planning several papers that we want to write out of this. And in a few minutes, Marc is actually going to go highlight some of the interesting findings that we have in this data. But there's much more that we can do. We can build web applications on top of this evidence base, and I'll actually show 2 examples of those that we've already created. But I sincerely hope that there will also be others, third parties, that will take up this evidence and analyze and process it in a way that makes it usable for clinicians and patients. To facilitate this, the evidence that was generated is following a well-defined results model. So it has well-defined tables and fields. I'm not going to go into them, but just so you know, it's there. That should make it easier to work off of these results and do something with them. All right, and now I'm going to do something very dangerous. I'm going to give a live demo. So the first application that we build, we're calling the basic viewer. So it provides the basic functionality for exploring what is in this evidence base. So this is publicly available on the website. Sorry? Oh, good catch. Yeah, we're in the wrong place. Probably doesn't work in Internet Explorer. Maybe it does. I haven't tried that. All right, basic viewer. So here we can specify the specific research question that we're interested in. And of course, I have a question in mind. I can tell which level of detail I'm interested in, either class, or we even define major class level. But I'm just going to say I'm interested in the drug level. And let's say I'm interested in lisinopril. And I want to compare that to hydrochlorothiazide. And the outcome that I'm interested in, just random, angioedema. And so what we're seeing here is that I've now specified the question I'm interested in. I can specify the data sources that I want evidence from. And so you see here the full list of databases that we ran LEGEND on. And we also executed a meta-analysis across these databases. But I'm actually just going to leave all of them checked because I want to see evidence from all of them. And I can choose one of the 4 different analyses that we performed. In this case, I'll just stick to the propensity score stratification and a on-treatment time at risk definition. And so what we see here on the right-hand side is the results from these databases for this question. So for every one of the data sources, and I see that I don't have evidence from every data source, I might not have enough data, I see an estimate, including from the meta-analysis estimate, the hazard ratio with a confidence interval and a p-value, and the calibrated hazard ratio and calibrated confidence interval and calibrated p-value. So if you, for example, focus on the meta-analysis, let's see. Oh, that was not what I wanted to do. Oh, sorry. we see that we have a calibrated hazard ratio of 1.92 with a confidence interval that goes from 1.49 to 2.61, leading us to believe that lisinopril has an increased risk of angioedema compared to hydrochlorothiazide. And this is actually a well-known fact that ACE inhibitors tend to increase the risk of angioedema. So we've reproduced a known finding here. If I click on any one of the individual databases, I actually have access to all of the diagnostics that were generated for this question. And so these are the artifacts that if I were to wanted to write a paper about this specific question, I would need all of these artifacts. So I can see that in this database, the CCE database, I had 647,000 people on lisinopril, 286,000 people on hydrochlorothiazide. I can see the distribution of follow-up time. I can produce the attrition diagram, which tells me, based on all the inclusion and exclusion criteria that we used for this study, how I got to those numbers. I can look at some population characteristics, both before and after stratification on the propensity score, like age or gender or some other characteristics of these patients. I can look at the propensity score distribution, which tells me that there's fairly good overlap. I, of course, can look at the covariate balance to see whether after stratification we achieved balance. And so here again we see that on the x-axis, the standardized difference of the mean before stratification was, for some of these covariates, very large. Like if we go all the way here to the end, we see that gender apparently was very unbalanced between these two treatment groups before stratification, but we also see that stratification properly adjusted for that and made these groups comparable in all these measured covariates. We also, of course, want to know whether there is any residual error, and so we can look at the systematic error that was measured for this particular design. So what we see here in the top row is the estimates for the control questions for the various true hazard ratios, so hazard ratio 1, 1.5, 2, and 4. And we see that most of these estimates were actually very close to the truth. So if they're within the red dashed line, that means that they're actually in agreement with the truth. And we see that the method is fairly unbiased, but still there is some residual bias. And if you look at the bottom row, we see that the empirical calibration properly adjusts for that residual bias. And we can also look at the Kaplan-Meier plot to see that there is some divergence between the two plots. So that is one application that we built. But just to stress this point that all of the evidence that we have here should be sufficient to write a paper, we created a second app, which we call Legend Med Central. And so this application is also built on top of that same evidence base, but is trying to represent that as if it was a large repository of virtual manuscript. So, I don't know, let's go back to lisinopril and hydrochlorothiazide for angioedema. Click search. So I'm now searching through this virtual database, and I see, oh, there are lots of papers on this very topic. How convenient. Let's pick a different one that we were looking at before. Medicare database. And so now the application is going to the database, the evidence base, and is pulling out all sorts of artifacts and has now written an abstract that contains information like what years were included in the study, how many subjects, and what was the observed hazard ratio. And then I can click on this button, generate and download the report PDF, and I have fingers crossed that this is working. And so what's now happening in the background is that this application is consulting the evidence base, getting all the evidence that it needs, and is compiling a paper, a manuscript that holds all the evidence for this particular question. And so here we have the manuscript as generated. We have a nice abstract. So we have a nice abstract, but we also have a good introduction on the problem at hand, hypertension treatments. We have a full definition of the methods that we use, including the data source that we looked at, the study design, the statistical analysis. We have our attrition diagram. We have the results. We have propensity score distribution, patient characteristics. Somewhere here should be the actual hazard ratios for the various analyses that were performed, covariate balance, and the Kaplan-Meier plots. So again, this is a gimmick, of course, but it is a gimmick with a point, that the evidence from legend is rich enough for you to write papers on. And so I hope you will do that. To finish up, and in conclusion, so grave concern exists over existing published observational research results, and I actually share those concerns to a great deal, and I believe that they're mainly due to study bias, publication bias, and p-hacking. I'll just ignore that. Large observational studies, as presented here, allow for empirical evaluation and calibration, unbiased dissemination, and providing a more complete evidence base. And so legend has been initiated to apply this to real-world problems. And so we started with depression, and now we've gone over to hypertension. And so now I give the floor to Marc, who will highlight some of the lessons learned from the results of legend. Thank you.
So those have been two very informative talks. How many people are still excited to be at the OHDSI Symposium? I'm actually happy that that's louder than the response that Patrick got. So Patrick introduced us to the totality of randomized controlled trial evidence for head-to-head comparison of antihypertensive drugs. So I've reproduced the same head-to-head plot that Patrick had over here on the left of my slide. And I'd like you to recall that this evidence is based from 40 different trials, and the number of individuals in these trials ranged from a low of 102 in one trial to 33,000 in the all-hat trial. But the median trial itself just had 1,000 individuals. So if we use legend at large scale across a network of database, can we provide first reliable estimates that are at least concordant with the existing knowledge of randomized controlled trials? But in addition to being reliable, can we enrich our knowledge base or the evidence we have, perhaps across all possible comparators, or those comparators which are most clinically relevant? And in terms of relevance, will these answers help us inform clinical practice? So let me make a comparison between the knowledge that currently exists and the knowledge that legend has given us. Here is the exact same plot looking at all of the head-to-head hypertension drug comparisons in legend, of which there are 10,278. For each of these comparisons, the smallest contains 3,500 individuals, while the largest has almost 2 million, and the median is over 200,000 patients. So let's return to some of those important clinical questions that Patrick introduced us to in the first talk. Let's think for a moment back to the 2007 American College of Cardiology guidelines and kind of their most important guideline, which was for the initiation of hypertensive treatments, your first-line agent should be a thiazide, a calcium channel blocker, an ACE inhibitor, or an ARB. And in this case, not a beta blocker. Thanks, CNN, for getting that one correct. In particular, they say there is inadequate evidence to support the initial use of beta blockers for hypertension in the absence of other specific cardiovascular comorbidities. Now, not to be outdone by their American counterparts, the European cardiologists published their own set of recommendations, which, although I don't have a copy here to wave in front of you, I have to say is much better written, much easier to read, and easier to digest than the American version. They have a competing guideline on what should be the first drug on which a hypertensive individual should start with. They say, amongst all hypertensive drugs, ACEs, ARBs, beta blockers, calcium channel blockers, and thiazides have demonstrated effective reduction of blood pressure and cardiovascular events in the same randomized controlled trials. And thus, basically all are indicated as the basis of treatment strategies. They do go on to say that beta blockers are usually equivalent in preventing major cardiovascular events. Basically, what they're doing is they're discounting the indirect evidence that was constructed in comparing beta blockers head-to-head against many of the other classes that the American systematic review included. However, they do mitigate that and say, except beta blockers are perhaps less effective in the prevention of stroke. So this leads to an important question. What should be the classes of first-line initiation? Should they include beta blockers or not? Can we provide the evidence to definitively rule them out, or are they as effective? So in order to answer this question, let's go back to the systematic review that Patrick introduced from the American College of Cardiology Systematic Review. And in particular, in terms of antihypertensive efficacy, we're going to focus on for a moment just myocardial infarction. But we'll remember that there are heart failure and stroke outcomes that are important. Over on the left, we have the network diagram that you find on page 158 or something like that of the supplement to the systematic review, which was then used in the guidelines. And honestly, I find these network diagrams really difficult to read and understand and appropriately interpret, because it's very unclear in terms of the hazard ratio that they're reporting, what is the target and what is the comparator. For example, in the ACE versus thiazide example, they give a hazard ratio of 1.2, but is that 1.2 saying ACE inhibitors are more risky, or 1.2 saying thiazides are more risky? And as a matter of fact, even in our own discussion up to a couple of weeks ago, we occasionally were flipping some of those numbers around. So let me introduce a new plot to orientate us, which is hopefully a little easier to understand. And even if it's not easier to understand, it's easier to generalize when we start doing comparisons across more than just 5 different classes. So over on the right, I'm going to introduce a heat map that basically presents the same amount of information in a more graphically easier to digest form. On the left of this listed, let's see if this mouse works for me. No, it does not, so let's not do that at all. We have the target comparators. So the target comparator could be an ACE inhibitor, an ARB, a specific subclass of beta blockers that are generally used for hypertensive treatment, one of the 2 classes of calcium channel blockers, the class that is generally used for hypertensive treatments, and thiazides. Each of these is compared to the comparator along the bottom. So if we wanted to look at what is, for example, the thiazide as a target versus ACE, which is what the systematic review is doing right here, we look down into this cell. So we have 10, there's 10 comparisons, there's 10 cells here. Within each of these cells, I'm reporting 2 different confidence intervals and point estimates. On the top is the point estimate and confidence interval from the systematic review. And you'll notice that in many of these outcomes, these confidence intervals are very large, signifying we don't have much evidence from the randomized controlled trials about the relative risk of myocardial infarction. The second set below there is both the point estimate and the confidence interval that we generate for the risk of myocardial infarction from the meta-analysis across the 8 databases in Legend. And the first thing that we want to look at to ask about reliability, can we believe the results that we're getting from these observational studies, is the concordance or discordance between our estimates in this primary outcome and what we know about the clinical trials. And I've colored the level of overlap for each of these squares, where kind of the gold, we won gold, is there's full overlap between the confidence intervals, or partial overlap between the confidence intervals. So both full and partial represent concordance, or they are not significantly different from each other. In the myocardial infarction outcome, we see that all 10 out of 10 of the legend estimates are concordant with the knowledge base from the randomized controlled trials. If we look across all 3 of the major cardiovascular outcomes, we nailed it. 28 out of 30 of the legend estimates are concordant. And the 2 discordant ones happen to be related to beta blockers in heart failure and are related to some of the indirect information that was used in the review. We'll return to beta blockers very shortly. Now, while I believe that high concordance is definitely an important first step in validity, I don't want you to interpret this slide to mean that legend bears no new evidence in terms of the relative effectiveness and safety of first-line agents for hypertension. Legend, you'll recall, wields much greater information in terms of kind of population diversity and population sizes that we can use to help refine these estimates and hopefully successfully tease out differences between agents, perhaps in terms of their effectiveness and in terms of their risk safety profiles. So let's do that. What we're going to look at in this slide is a comparison between the information available from the randomized controlled trials and legend for the risk outcome of myocardial infarction with making comparisons across the 5 different major classes. And on the right, I've plotted a heat representation of the hazard ratio estimates comparing each of these 5 different classes. And you'll notice that in this heat map, each of those blocks happens to be gray, signifying that the randomized controlled trial evidence shows no significant difference between the relative effectiveness of each of these different agents. If we go over to the right plot, okay, good. The colors are better up there than they are here. If we go over to the right plot, we see the same meta-analysis in legend. So let me help you kind of interpret what the different colors mean. I've listed the hazard ratios on a scale of green to purple. Green means that the target is either more effective green means that the target is more effective or safer. So the risk of the event is greater in the comparator. Whereas purple means that the comparator is more effective or is a safer drug. So let's glean what some of these results might tell us. Well, the first thing we'd want to look at is how do beta blockers really stack up against the 4 different classes? And we see that with the exception of the comparison with ACE inhibitors for MI, beta blockers are less effective than the other 4 classes in preventing MI. So that seems pretty solid evidence, given that our meta-analysis for each of these studies is using between 1 to 2 million patient studies. But before we can accept this as a definitive answer, we need to look at the study artifacts to ask, is it a valid comparison? Were we able to appropriately approximate that idealized target comparison and control for additional systematic residual in making these estimates? Also, there's another surprise result that I think we might want to dig into, is this green box right here in the comparison of thiazide diuretics to ACE inhibitors. It's green, symbolizing that thiazide diuretics are significantly better at reducing the risk of myocardial infarction than ACE inhibitors. So let's dig into this result a little more to answer that question, kind of how reliable is this hazard ratio estimate showing a difference between thiazide and ACE inhibitors? So the first thing we want to do is look at the concordance comparison between the legend meta-analysis estimate and the systematic review and the individual clinical trials. So what I've done here is replicated a table that Patrick showed earlier, saying that the totality of randomized controlled trial evidence looking at thiazides versus ACE inhibitors came from 3 trials, where across all patients, there were about 18,000 individuals who had been randomized to a thiazide versus 12,000 individuals who had been randomized to an ACE inhibitor. And the meta-analysis estimate was on the order of like 1.2, as you can see from the forest plot over on the left, with a very large confidence interval because of the disparities between the trial populations and the trial results. Below that, I've listed the meta-analysis hazard ratio and total number of patient counts in the studies for the Legend meta-analysis. In this analysis, we're comparing over 630,000 first-time users of thiazides to almost 1.7 million first-time initiators of ACE inhibitors, with a calibrated hazard ratio of 0.8, suggesting that thiazides are safer than ACE inhibitors, and a confidence interval that does not cover the null value, showing that this is statistically significant with a calibrated p-value of less than 0.05. So we have a result that is concordant not only with the meta-analysis, but with the largest randomized controlled trial, but it's reduced our uncertainty in that null result to the point where we have sufficient information across our network to identify the significant hazard ratio. In order to believe that estimate, we have to show that this is a valid comparison, that we are able, in our observational study, to approximate that idealized randomized controlled trial. Martijn went through many of the artifacts that I'm going to use for this demonstration, and you can pull them up yourselves as we walk along through one of the web applications that we've developed. Most of the figures that I have here have been taken directly from the automatically generated report. So Martijn explained that we're using a large-scale propensity model that will help control for observed confounding. And one of the first things we want to do is ask, are there a sufficient number of individuals within clinical equipoise? Meaning there's a chance that they could have actually been assigned to the other treatment group and been their own counterfactual. And as we look at the preference or propensity score distributions for these two comparisons, there's a large population of individuals who could have been involved in that idealized randomized trial. So based on that propensity score stratification, we next want to look at balance, or the characteristics of these patients after they've been artificially randomized. And in this study, we achieve balance across all almost 11,000 baseline characteristics that we have for these individuals if we look, for example, in the CCAE database. What's very interesting is, as a clinician, when I start thinking about treating hypertension, one of the things I really want to know is, what's the individual's blood pressure and how severe is it? So we might want to ask, are we able to balance our cohorts on blood pressure, or is there some unobserved confounding based on unmeasured blood pressure in the claims data that we're really not accounting for here? Well, one of the advantages of executing across a large international network is several of our databases are actually EHRs, and they actually are EHRs of considerable size, and one example is Panther. And within Panther, there are a large number of blood pressure measurements for most of these individuals. As a matter of fact, I hear that some of these blood pressure measurements come from wearable devices. Now, I don't know what the technical implications are for that, but I have to say that's pretty cool that we're using wearable devices in an observational study. No one? Okay. No. So what I've done in the table listing what look like blood pressures is reported the population mean blood pressures at baseline of individuals who are assigned to both thiazide and ACE inhibitors, both before and after balancing. And what you'll see is after balancing, the comparability statistic that we want to look at, the standardized difference of mean between populations, is much less than the nominal 0.1 that is generally used in the field to say we've done a fair job on making sure that these populations are comparable in terms of their baseline blood pressure. What's also very interesting is these mean blood pressures, at least systolically, are spot on to the mean baseline blood pressures reported in all HAT. And the diastolic blood pressure is only off. It's actually increased a little bit as the American population in our blood, not only do the thresholds come down of what says hypertension, but our actual blood pressures creep up a little bit over the years. So I want to reiterate a point that none of these blood pressure measurements were actually used in building the propensity score model. The propensity score model only used information that was available in the claims and in the EHR data. But even just using the claims information, or information that you would only find in a claims database, we're able to balance or adjust for this effectively unobserved confounder after stratification. Martijn talked a fair bit about interpreting the calibration results, which give you a plot of what the negative and positive controls look like. In terms of this study, I'll just say that calibration does return near nominal hazard ratio estimates in the ranges that we need, which are around 1 or 1.5. And so I would say that we have very good diagnostics in this comparison. Our cohorts are comparable. They're comparable both in the observed information that we have, and I believe, based on looking at blood pressure measurements just in the EHR database, also the unobserved blood pressure measurements across the other databases as well. And the calibration does a great job in controlling for the residual systematic bias, given the nominal coverage that we have around the hazard ratios that we're trying to estimate. So I'm certainly willing to conclude that thiazides as a class are more effective than ACE inhibitors in preventing acute myocardial infarction. But when you're getting a prescription for a drug, your physician doesn't just write down, hey, why don't we give this individual a thiazide? As a clinician myself, I actually have to pick an individual drug. And here's a real story. I'm a type 1 hypertensive, and in discussing first-line treatment with my physician several years ago, she said, hey, I'd like to start you on a calcium channel blocker just because of other comorbidities that I have. And I said, that's great, which one? And she said, I don't know. So what did I do? I said, I'm going to go with the most prevalent. Now, we should be able to use Legend to extract a lot more information about the relative effectiveness of drugs within classes, and particularly their safety profiles. So here is the same heat map, but instead of comparing at the class level across the 5 different classes, this is comparing at the individual drug level across the 58 different monotherapies. Up at the top, they're listed in order of the thiazides, the ACE inhibitors, the ARBs, and the calcium channel blockers. One thing that becomes pretty self-obvious from a plot like this is, yeah, we believe that the first-line agents are more effective in this case in preventing a composite of MI, heart failure, and stroke than the second-line agents. And the way that you can see that is, remember, green means it's good to the left. So if we're comparing, wow, never use somebody else's computer. So over in, so here's where we're comparing the first line to the second line, and there's a whole lot of green, so on average suggesting that they're more effective in reducing the risk of these 3 primary outcomes. Within classes, we do see a small number of differences in this efficacy. Some of the differences you might see might relate to, for example, captopril up here. But I'd like to say that, for example, captopril, the differences failed our individual diagnostics in that we were not able to appropriately replicate that idealized trial. However, there are a number of cross-class comparisons that do very well approximate that ideal trial, and I'll return to some of them in a couple minutes. The next guideline that Patrick mentioned from the American College of Cardiology suggestions was the Class 1 recommendation that was based on expert opinion only. And it was that initiation of antihypertensive therapy should start with 2 agents and not just 1. It turns out our European counterparts have made the same recommendation. Combination treatment is recommended for most hypertensive patients as initial therapy. They go on to reiterate a very important point. No randomized controlled trial has compared major cardiovascular outcomes between initial combination therapy and monotherapy. All right, let's do it. So let's compare monotherapy, so starting on 1 of the 5 different classes versus starting on a combo therapy, including 2 of the 5 different classes, looking at the relative risk of myocardial infarction. So on the left, we have the monotherapy targets, and on the bottom, we have the dual therapy comparators. Over on the top and the bottom of the slide, I've listed kind of the relevant prevalence at which people take these drugs out in the wild. So in terms of monotherapy, ACE inhibitors, as Patrick mentioned, are used the most. In terms of dual therapy, it's a combination of an ACE and a thiazide. Well, what do we immediately see? Well, the part that stands out that we'll walk over very quickly is, again, just taking a calcium channel blocker, just taking a beta blocker is probably a bad idea. But within the region of the treatments that we really care about, those that are used the most, for example, right here, should I take an ACE or should I take an ACE and a thiazide? Or alternatively, should I take a thiazide or an ACE and a thiazide? We show no significant difference in the relative risk for myocardial infarction. We actually find similar non-results for differential efficacy for heart failure and stroke. But efficacy should not be one's only concern. There are also the safety risks of drugs. If 2 drugs are just as efficacious, I'd probably like to take the one that's safest. In Legend, we've looked across on the order of 55 different safety outcomes, and I've just picked one here, kidney disease. And the reason I've picked kidney disease is many antihypertensives, particularly the diuretics, tend to physiologically act directly on the kidneys, and so you might expect that there could be adverse reactions. So this is looking at the relative risk of kidney disease if you start on one of these monotherapies versus the relative risk of kidney disease if you start on any of these other dual therapies. And what you might notice is it's pretty green, suggesting that the monotherapies are significantly safer than the dual therapies. And in particular, we're interested in this column, which is individuals starting on the most prevalent ACE versus thiazide, versus their 2 constituent drugs, thiazide and ACE inhibitors. But before we take this as given, we need to ask ourselves, are we able to approximate that ideal trial? So I'm going to dig down rather quickly into that description just for the ACEs versus an ACE and a thiazide, for the only reason that ACEs are the most prescribed antihypertensive out there. So again, we have the artifacts that we take out of the legend results model. The first thing we might ask is, how many individuals are we looking at? So in comparing new users of ACEs, we have over 750,000 new users of ACEs, to whom we're going to compare to over 200,000 first-line individuals who are first-line treated with an ACE and a thiazide. And we'll ask ourselves, are these two populations relatively comparable? And actually, I think there's actually remarkable overlap between cohorts. These are almost randomized populations. It looks almost like someone just flipped a coin to decide you should start on an ACE or you should start on an ACE and a thiazide. After stratification, we achieve balance across all approximately 8,000 baseline characteristics that we know about these individuals. So let's dig into the estimate for kidney disease. Is combo therapy actually a little riskier than dual therapy? And we can look directly at the calibrated point estimates for the risk of kidney disease and CCAE. I won't go over them at the moment because I'm going to talk about the meta-analysis very quickly. And here's a Kaplan-Meier curve showing the kidney disease-free survival for individuals who start on an ACE versus individuals who start on an ACE for a thiazide. Across our meta-analysis, the hazard ratio in favor of the monotherapy, be it an ACE or a thiazide, is about 0.8, with a rather narrow confidence interval, showing that the monotherapy in these two cases are safer in terms of the risk of kidney disease than the dual therapy. So what's the take-home message? Well, across our meta-analysis, the monotherapy here have comparable efficacy, but they have a greater safety risk. So maybe it is a good idea to start on that monotherapy, and then if you need to, you can step up to dual therapy later. The final question in the last 5 minutes that I have that I want to touch on goes back to a head-to-head comparison between two agents within the same class. In particular, the VA Diuretic Comparison Project, where they're looking at the relative efficacy of chlorothalidone versus hydrochlorothiazide. So let's start by looking at the relative risk of myocardial infarction in the CCAE database to see how many people we have in each of these treatment arms, how comparable they are, and how well controlled is the study. In CCAE, there are just over 14,000 individuals who start by taking chlorothalidone. In the same database, there are almost 300,000 individuals taking hydrochlorothiazide, and with the event rates that we see in this database, based on those population sizes, 14,000 and over 250,000, the minimal detectable risk that we'd be able to see is a hazard ratio of 2. So there better be a whopping effect between these drugs if you're going to get a positive result. So although these populations are a very different size, are they comparable? Are there individuals who could have received either of the two drugs that we can use through propensity score matching to approximate that idealized trial? And it turns out there are, right? Although there is a population of individuals who seem to only really get thiazides, there are a sufficient number of individuals who who could have gotten a chlorothalidone or hydrochlorothiazide. As a matter of fact, through this propensity score matching, we achieve balance across all of the baseline characteristics that we have about these individuals. So let's get a calibrated hazard ratio estimate for the risk of MI across these two drugs. Well, the estimate is about 0.7 with a confidence interval that ranges from 0.4 to 1.2. Basically, no significant difference in the risk of MI across these two drugs. That's kind of bared out if we look at the Kaplan-Meier, and this is sort of, acute MI-free survival for, of course, individuals with hydrochlorothiazide. There's a large number of them, so we have relatively tight confidence interval, and individuals on chlorothalidone. There are not nearly as many of those, hence the wider confidence intervals. What I'm not going to show in sake of time are kind of the calibration plots. They do demonstrate that in this design, there's really only minimal systematic bias, and it is controlled for. We do get the nominal operating characteristics that we expect for the calibrated hazard ratios. But we don't just have to run it in CCAE. We could run it across all of the databases where there is chlorothalidone exposures and look at what the results are for the meta-analysis. Across all of the Legend databases, there were approximately 25,500 new initiators of chlorothalidone and over 500,000 new initiators of hydrochlorothiazide, right? Leading to a calibrated hazard ratio that is not significantly different from 1. However, the story is a little different when you look at the safety profile of these two drugs. So this is a new plot, so let me walk you through it very slowly. Along the x-axis of the plot, we're going to consider a large number of the cardiovascular outcomes and safety outcomes. And for each of these cardiovascular and safety outcomes, we're going to plot the estimate of the hazard ratio if it's significantly different from 0 to remove a large amount of the noise that you would see across here. And we're going to plot it for the meta-analysis and the 5 largest databases. Of course, we see no significant difference in any of the cardiovascular outcomes for these drugs, but we do see some difference in terms of the safety profile. And so hazard ratios going up in this direction mean that chlorothalidone is a safer drug, whereas hazard ratios down in this direction indicate that hydrochlorothiazide is a safer drug. And it looks like in terms of safety seems to favor taking the hydrochlorothiazide. One of the most important points to look at is these bars give you an idea of what is the relative prevalence of each of these different outcomes, right? So here's an outcome that's very prevalent and has a quite high hazard ratio greater than 2. So it's probably one of the most important effects. And it's a differential hyperkalemia. It turns out that most of the effects in this area are issues dealing with electrolyte imbalance. So the risk of electrolyte imbalance appears to be greater in individuals taking hydrochlorothiazide. And this is kind of consistent with the idea that's even related in the ACC guidelines, saying that hydrochlorothiazide was sort of a more potent drug and had a longer half-life, and perhaps those have a greater effect on the kidneys. So what does this mean in terms of the 10 million? It was actually much cheaper than the 100 million that Patrick wants to run these large trials. The $10 million VA trial comparing these two drugs. Well, the VA trial is going to look at almost 7,000 7,000 users of each of these two drugs compared to our Legend meta-analysis, where we have looked at 25,500 and over 500,000 new users of hydrochlorothiazide. The average follow-up time in the randomized controlled trial will be about 3 years. It turns out the median follow-up time, if we do an intent to treat analysis within Legend, is a little less. It's 2 years, but 25% of these Legend patients have follow-up that is greater than 4 years. So even if we just think about taking the 25% that have follow-up greater than 4 years, you take 25 divided by 4, it's still a lot greater than the number of individuals that are going to be enrolled by the VA. And our maximum follow-up continues to 16 total years. So I'd like you to bear in mind there are some caveat differences in the design of our idealized trial, basically no antihypertensive, any age, versus already on treatment and older. But with those caveats in mind, what do we find? Well, we find a non-significant difference in terms of the hazard ratio for the MI. But you'll still have to wait another 4 years and spend off the rest of the $10 million to see what the VA is going to come up with. suspect it's going to fall right in our estimate. So legend, some important take-home messages is the legend evidence was very concordant with kind of the totality of randomized controlled trials for head-to-head comparison in hypertension. Where those randomized controlled trials exist, we did very well. But the randomized controlled trials left many unanswered questions. With the legend evidence, we can look at a large number of comparisons across many different outcomes, including safety profiles and across diverse data sets. And we can use those to answer some clinically relevant questions. Now, in this talk, I've highlighted only a couple of those clinically relevant findings, and I want you to keep in mind that each of those obviously requires kind of clinical adjudication and peer review, but with that in mind, let me highlight what some of those findings were. Basically, not all of the first-line agents are equivalent. Beta blockers are less effective in preventing MI than the other 4 classes. And perhaps the Americans got it right. They got it right using indirect evidence. Now we have real evidence, and the Europeans are a little off. We do find evidence that thiazides are more effective than ACE inhibitors. And that might affect clinical treatment in terms of drug choices that that physicians and patients will make. In terms of combo therapy initiation, well, there really is a lack of evidence that combo therapy is better. We find a non-significant difference in the efficacy between starting on a monodrug versus starting on a combo drug. However, we do have strong evidence of an increased safety risk for starting on a combo drug, so perhaps the monodrug really is the best choice. And in terms of the VA trial, well, we got to wait 4 more years, but I'm pretty sure the answer is going to be no effect difference. A large amount of work has gone into the last 3, lies behind the last 3 presentations that you've seen. A lot of that work, but not all of it, most of that work was done by 2 different legend scientific groups. I've listed both the scientific advisory group up here and the clinical advisory team. I'd like to take a moment myself, and hopefully you'll join in applauding all of the individuals who have helped make legend a reality. Thank you. We're going to do a short Q&A session.
So we've got a few minutes. I know that was like drinking through a fire hose, but if anybody has any questions or comments, we'd love to engage the community in the conversation.
Yeah. I'm wondering if your studies have looked at no drug as one of the comparators.
So the question is, what about no drug as a comparator? And so it's a interesting methodologic issue to think about how one would even think about trying to model that. And in particular, I think in this particular case where the guidelines is saying you are going to need to take a drug, the question really is not about whether or not to take a drug. The question is which drug to take. And so the scope of this has been to focus on what the guidelines is, which is about which drug to take. Yes?
Possibly a naive question, but I was wondering if you could talk a bit about, given the large number of hypotheses being tested, whether or not the 95% confidence interval is still appropriate, and if there's any risk of, like, family-wise false positives.
We do generate a large number of effect estimates. But what's important in interpreting the effect estimates is the number that you look at to claim that are significant. Although we have a very large knowledge base, we'd like you to come at it with a specific research question from which you can limit a priori the number of hazard ratios that you're going to need to evaluate to assess whether there's an effect or not. So most, or at least the clinical vignettes that I went over, there were a priori hypotheses based on the clinical guidelines. So it was really just an effect estimate that we look at in, for efficacy or safety in the meta-analysis. Did it cover 0 or not? And we were well calibrated for those single questions. Yeah, just talk loud. Oh, yeah. And talk loud.
Wow, it's on. Okay. So I had a methodological question and a subject matter question, actually, I guess. Martijn, you had talked about in your discussion of the methodology of legend that one of the ways, and actually you all kind of talked about this, that you are ensuring that the research is appropriate is by asking questions where you already know the answer. And so you both presented questions where you already knew the answer in order to confirm that your methods were working. One thing that occurred to me as you were presenting was that there are questions that we already know the answer to, but there are also areas where we know that observational science did not actually answer the question correctly. And I'm thinking particularly of hormone replacement therapy. I'm a woman, I followed that. And I was thinking that another way that you could confirm the approach would be to take something like that where it is known that observational data science did not give the correct answer, and then we did a clinical trial and it gave a very, very different answer, and to reproduce those effects, both the observational and then followed by the correct effects.
That sounds like a really good idea, yeah. we should talk and maybe
yes,
see that.
I would love that.
I got it written down. It's a good one.
Check.
So very nice result. I probably cannot say legendary result. I have to say impressive result. So I have a question. In your methodology, I think we have a nice machinery, and the goal is to apply it to more domains or improve the machinery. So my comment or question is about improving the machinery. And I like the distinction between the efficacy outcome and safety outcome. So if you are only sticking to the new user cohort, it makes sense for the efficacy ones. But I'm wondering if for the safety outcome, we could improve the machinery, just like the VA study is actually studying the people on the drug. What are your thoughts on possibly improving ever the machinery to study the safety outcomes with a non-new user cohort study? And actually, there's a similar parallel cohort. So when you are saying new user for T, another comment is, what about the new experiencer of O? And I wonder whether in all the designs, it's always like my first stroke, or what if I'm having my second stroke more severe than the first one, and am I out from all the other machinery for if I already had my first O?
Yeah, you want to start? Yeah. So those are very good points, and certainly, actually, some of those we considered, like the question of whether or not we should focus just on first line or on second line is one we contemplated at the beginning. But at the time, we just felt that to be a little bit daunting, because if you're talking about second line, that then begs the question, well, what was the first line? So are we now going to compare people that are on drug A after they took drug B, and are we going to compare them to people on drug A that took drug C before? So we haven't yet figured out a way to make that feasible, but that doesn't mean that it's not an interesting question to look at. So certainly, this was the first iteration of Legend for hypertension, but we envision that there will be many more where hopefully we can expand into answering more and more and other appropriate questions for hypertension.
And I will just add to that, the choice of the methods here were guided by the clinical questions and the target trial that we were trying to emulate in this particular case. So it is not that we're saying that you should only do a new user cohort of first-line therapies. That is not a constraint at all. Rather, that was the clinical question posed in the guidelines that we sought to produce evidence for. But you're absolutely right that there are other very important clinical questions that require both different cohorts, but also different designs. So you mentioned like conditioned on the outcome. You know, we within the OHDSI community, we built a large suite of self-controlled designs, including self-controlled K-series and self-controlled cohort designs that have demonstrated to work reliably in producing good effect estimates. And so when it calls for those appropriate designs for different clinical questions, we would hope that that becomes part of this legend system. Yes?
Yeah, thank you. I like this session very much, and I have two questions. One for Patrick, actually. Both questions on the same issue is on treatment effect, and what do we really mean, and uncertainty. So I was a bit confused by the presentation that the LHEAD trial has a kind of neutral effect, relative risk 1, confidence interval 0.9 to 1.1, and then we add another trial, and then we get a confidence interval 0.78 to 2, right? So essentially just adding heterogeneity. So can you comment a bit on this distinction, right? You did not really explicitly mention heterogeneity, I think, but I think when you think about this, it's really essential.
Yes, thank you for the comment, and that was the very slide we took out last night. So what I didn't mention, because we thought it might be a little bit too nuanced, but what's fascinating is the meta-analysis has more uncertainty than the individual trials. And the reason that's happening is because the two trials that produced estimates were not fully concordant. And so rightfully so, the random effects meta-analysis is basically presuming that these studies represent a sample of studies in a universe of answers. And so the two that it drew from didn't agree, and therefore to produce an appropriate random effects meta-analysis, it actually had to widen the effect. What's fascinating about that is that test of heterogeneity should have told us we had a problem. And so rather than having a composite answer and having confidence, it should have actually been the case that we said, wait a second, there might be something going on here. And so what we think is very important is a meta-analysis is an appropriate thing. We've got to figure out some way to synthesize this down to something meaningful. But at the same time, we shouldn't lose sight of the fact that you need to be able to trace that. And one of the most exciting things for me about the OHDSI community is heterogeneity is something we should be embracing. It's something that we should be taking advantage of. And by having a network of databases around the world, we can start answering questions that weren't ever conceivable before.
Yeah, thanks, great. May I continue with one brief question to Marc, then on the coloring, on the green and the bluish. So how do you summarize there the effect estimates and uncertainty in that one color?
So that misses out on it. So the cutoff spectrum that I was using there was actually the least extreme bound of the confidence interval. So it includes both information about the direction and the uncertainty, and you can think of it as kind of a conservative estimate of what the hazard ratio may be.
Okay.
But that's an arbitrary choice.
Yeah, I'd like to discuss that further. Thanks.
Anna?
First of all, thank you for coming to our world, because all of you have made a big difference. I have been very concerned for several years about the lack of traceability to the original data. I have learned that data is transmitted through a multitude of interface engines, and because there is a lack of interoperability of the data when it's being generated, then decisions are being made during transit that damage the data. And I can only imagine, the results that you will obtain if you have fully traceable data. Then I think that we all need to work on trying to get interoperability implemented as the data is being generated, because then we can apply artificial intelligence, we can get better evidence, etc. Thank you for the work you are doing.
Thank you, Anna. And I will say, I guess we kind of glanced over it quickly, but clearly one of the key focuses within the OHDSI community is to try to establish reproducible practices. So to be explicit, everything you just saw, not only the results are available, but all of the source code to run this is publicly available on the OHDSI GitHub. There is documentation and a protocol that describes what's being done. There is full traceability from the common data model all the way through this results. Where we need to go as a community is to improve the step to go from the source into the common data model, and that's an opportunity and a challenge that we as a community need to reconcile. But what we can say is if we can solve the traceability issue to get from source data to the common data model, I hope this encourages many of you that there's a wealth of opportunities of what we could do once we get there. Yes?
I have two questions. One is missing data. Second one is causal effects. In your large-scale analysis and study, how did you handle missing data? Because observational studies, you can impute the data. For example, BMI and age or gender, sex, you can impute easily if you miss from randomly. But if you try to impute observational data, like blood pressure and things like that, it gets complicated. And there are techniques like hard deck imputation techniques. But I just was wondering what was the imputation techniques if you use for missing data?
So as it relates to how we specify this analysis, we use the presence of data to represent the features that we could study. So when we do propensity score matching, we're looking at the occurrence of conditions in drugs and procedures. And if they exist, we say that it's there, and if they don't exist, we infer that it did not occur. That is clearly subject to measurement error that's well established. We do not impute measurement values, and in fact, as Marc showed, we don't even use measurement values in our propensity score. Rather, we used everything else, and then we checked to see whether the measurement values, such as systolic blood pressure, actually achieved balance despite the fact that they were not used as covariates. And we were quite reassured to see that balance was adequately achieved.
Thank you.
Last question. Yes.
Thank you. At the beginning, you mentioned that observational research is a bit of an image problem. Some people didn't necessarily believe it over the interventional stuff. Do you think there will be many people who will now be convinced who weren't previously convinced? In particular, if we assume that observational research continues to have confounding by indication and systematic error, does the precision really add anything, or do we just have more precision around the wrong value?
So the point that I was trying to make was that if we continue down the road that we've gone for the past decades, which is just doing one study at a time and trying to publish one estimate at a time, or not, if it doesn't get published, we will never get out of this rabbit hole. And so what we're trying to achieve in Legend is basically a new way of doing observational research that does solve this problem. I hope we've convinced at least some of the people in this room, but we certainly have a long road to go before we convince others of that. So I think we're just at the beginning of having people believe that this is the way to do observational research.
Very good. So I want to thank you all for your patience in putting up with humoring us for a couple hours in this terms of results. Our next item on the agenda is actually to start our collaborator showcase. So the poster sessions and the software demonstrations are outside. For those of you that I think, are we doing evens first? Evens first? Or odds first? I got a 50-50 shot at this, and I'm like 100% sure I'm going to get it wrong, whatever I say. I'm going to put my bet on odd and find out that it's even. It's even? It's even. Okay. So those of you who are poster presenters who have an even number, we encourage you to go to your poster so that you can engage with the community. Those of you who are not an even poster, we encourage you to go to the even posters and make a friend and network and talk. The software demonstrations, there's half of them will be out both. There's some posters behind you in that kind of corridor. There's some posters and demos to the right of the room. And actually, we have a little bit more of the foyer going back. So we've got an hour here for you to engage and network as a community. And then we'll return for the second portion of the Collaborator Showcase at 12. Oh. Yeah. Oh, yeah. An hour and a half. So you got lunch, you got Collaborator Showcase. Be back in this room at 1 p.m. Thank you.